All right, welcome back for the second video. We're going to continue talking about the acetabulum. And if you look over here, you can see the outline of where the acetabulum is coming off the pelvis. One of the first definitions we'll talk about is related to the depth of the acetabulum, basically how much space or surface area the socket, the concave portion of the hip joint, takes up. And there's a measurement for this, and that's going to be called the center edge angle. So if you were to look at this, you would take basically the middle part of the femoral head right there, and then you would measure out to how far the rim of the acetabulum reaches. And so you can measure out that way as well, just because you could see the end of the acetabulum there. And then if you were to go straight vertical from that, the space in between there would be your center edge angle. The normal value for this should be around 25 to 40 degrees. Obviously, the greater that angle, the more coverage of the femoral head within that socket is. And there are some uh, pros and cons to having more acetabular coverage, and we'll come more to that in a few slides. The other one is going to be related to the blue angle here. So let me just clean up this slide a little bit. All right, so talking about this angle here, the way that the femoral head is positioned here in relation to the shaft forms this angle of inclination. And then as you could tell from the picture, both the angle of inclination and the center edge angle are measured within the frontal plane of movement. And we'll talk a little bit more about the acetabular coverage as it relates to the center edge angle in the next slide. So let's talk a little bit more about the two different types of acetabular morphology. Basically, you could have an acetabulum that is too shallow and that it doesn't cover a large portion of the femoral head. And we know that typically 25 degrees is normal. You have this borderline range where the center edge angle is 16 to 25. It's smaller than normal, but still borderline, and then under 16 tends to be a definite acetabular dysplasia. So if you think about that, what would happen if you have the socket taking up less coverage of the femoral head? What conditions might that predispose someone to? How might that affect their range of motion? So thinking about that for a minute, I will give you some time to think about that. And then we'll have a little quiz question on here about how having a shallow acetabular surface would affect the mobility and the stability of the joint. So let's say that your angle, instead of being where it is here, let's say it's positioned more like this. So you have a more shallow acetabulum. Still, the femoral head is the same size, but in a more shallow acetabulum. How do you think that would affect an individual's range of motion as they go into flexion or extension or even abduction? How do you think that would affect their range of motion? Yes, so generally, this would allow for a greater range of motion because the femoral head is not necessarily being blocked right in there. So it has a greater range that it can go. So if you think about maybe doing a split, you could have the femur basically go all the way out here without having as much blockage or bony blockage there because it would be coming up through that angle at that point. Now, let me delete some of this here. There we go. So the acetabulum is still shallow. How do you think this would affect the stability of the joint? Do you think it would be a more stable or a less stable joint? Yes. At this point, with the smaller center of edge angle, you would have less inherent stability at the joint due to the shape of the bones, which rely more on the muscles and the other soft tissue, such as the ligamentous structures. The three main ligaments of the hip would be under more strain or more pressure to support that joint. And if it was able, if those ligaments and muscular tension and other structures are unable to support that joint, it's more likely to predispose into a dislocation. Or the other thing that may happen is it just may move more, and that's where you could fray upon the acetabulum, typically in that area, and cause some type of labral tear or other impingement type situation. So that is acetabular dysplasia, or a small acetabulum relative to the femoral head. Let's talk about coxa profunda next. Coxa profunda would be more like this scenario where you have an excessive coverage of the acetabulum over the femoral head. So, how do you think this would affect the overall mobility of the joint? Just the opposite. It would be an overall decreased mobility of the joint. But the trade off for that is you would have more stability because you'd have a deeper socket essentially for that femoral head to sit into. And so this would typically be the case when there's over 25 degrees for the center edge angle, and this could be up to actually 40 degrees or higher in some individuals. And then with coxa profunda, another situation that may occur is there still could be some impingement of that labrum. So this can happen either with dysplasia or profunda because you're trying to get that motion that occurs at the hip, and because you have the more deepened socket, you may be trying to force that movement to occur further, and that may impinge or compress upon some of the acetabular labrum. All right, so we made it to the third slide, which means we should probably introduce a little cheesy joke. So this one, I think you'll like. It's about a bicycle. Why couldn't the bicycle stand up by itself? Because it was too tired. Too tired. That's a good one. Okay. With that, we will make Mr. Cheesy joke section exit. There we go. So now we'll continue talking about the labrum labral portion of the acetabulum. So this is very analogous to the shoulder labrum in that it has a portion here that can help to deepen the socket and provide a little more stability for the hip joint. It is wedge shaped, and because it is fibrocartilage in nature, you can imagine it has a limited blood supply, but it does have proprioceptive and nerve fibers within there that'll sense position changes and trauma and other things to the area. But there is this zone for it where it's calcified and it's denser in that portion, which is a critical part to the stability that it provides within the hip. You will see another thing I'll point out in this image, because I like to show this, is that the articulating surface of where the femoral head sits is in this moon type shape. So they call this the lunate surface as well. But that's the flattened cartilage, the articular or hyaline cartilage for where the femoral head and the acetabulum meet. And of course, consequently, in the middle, you have where the ligamentum teres would also support the femoral head within the acetabulum, which is a relatively large fossa as compared to the glenoid fossa at the shoulder, where you have another ball and socket type joint. All right, so here we are on the next slide, and you can see the shape of the femur. You can see the blue line there, picturing the angle of inclination. And I just like this. So as I was saying, so speaking of the psoas, you can see where the psoas would attach within here, within the lesser trochanter, which is contrasted to the larger, easier to palpate lateral aspect here, the greater trochanter, where you have, of course, the gluteus medius and minimus attached, the piriformis, a few other muscles as well. And typically, if you feel that on the side, that is where we like to line up the handle of a cane or potentially other assistive device, as we know the location of where to put that. So it's an important thing to be able to palpate and find on your patients. There is the fovea here. The ligamentum teres is going to come out there. And so what that's going to do is it's going to provide a little bit of stability, basically an anchor for the femoral head into the center of the acetabulum. But you can get from this picture, you can get an appreciation of how the neck is thinned out, and there's an area that's going to be limited there in terms of strength. But another thing is you could look at how the femur can be absorbing shock. So if the ground reaction force is coming up this way, somewhat this neck is absorbing a part of that force instead of transmitting it directly into the acetabulum. So it's a distribution network as well, which is quite beneficial for us. And those are the main things to point out on this slide. All right, and that brings us to our last slide, showing a little bit of a better depiction of the weight bearing and the loads that go on throughout the femur. So, of course, you have force, ground reaction force coming up this way. Then you have the body weight coming this way. So there's going to be a transmission through the SI joint, which is going to go through the pelvis, and then it's going to provide force input this way. So that's going to make it go down through the acetabulum to the femoral head. And so then you have these other forces coming up and other forces getting compressed within there. And what that's all going to do is it's going to create this area right in here where the bone isn't quite the strongest. So this whole portion right here is within the neck of the femur, or the femoral neck. And this zone right here, where it's going to be the weakest, is going to be the zone of weakness. That's going to be right here. And that's where patients are most susceptible to fractures. And obviously, the surgery for that would involve going in basically with a rod to support that structure, and they may secure that in different ways. So I got a lot of colors going on this slide here. I don't know if that's helping to make sense, but there's some other x-rays and imaging in the book or online that you can see for what a hip fracture repair might look like. But at least it gives you a good idea of what the zone of weakness would look like and how that is positioned. Okay, so that wraps us up for this lecture. That's about it, and I'll see you in class. Thanks. Bye bye.